Okay, so Katie, we're good to get started, or should we wait a little bit?
We are good to get started.
Okay, awesome. So first want to say hello. My name is Kiranpreet Chawla. I am an OBGYN here at the University of Maryland. To kind of give you a backdrop of who I am, I'm going to start my everything and then we can kind of get going. So hopefully you guys can see my PowerPoint screen. Does that seem good to go? Yeah?
Yes.
Perfect.
Yes.
Okay. So just to start off, this is kind of me in a little nutshell. I've been an OBGYN for a long time. I realize I'm old. Every time I'm teaching the medical students, I realize how old I am. So it always is kind of amusing to me. This is my residency class. We were considered to be the Benetton class. That was what we were called. That's how old I am. I know what Benetton commercials are. And there's just like a huge amount of diversity within my class. I was an NYU in New York City, graduate of 2008. I've been here on faculty since 2012. My focus clinically is on general women's health. I do a ton of work with global women's health as well. And my minutia focus, the part of OBGYN that I kind of like love is cervical cancer screening and prevention. I also do a ton of just normal Nelly taking care of women types of stuff. And just so that you're aware of that. As we go through everything, please feel free to write some questions in the chat if you should have any. Katie is, oh my God, I just blanked on your last name, is going to be with us and she's going to be manning the chat to help me out if there's any questions there. And I'm going to try to kind of go into the chat as much as possible to be able to answer your questions, and hopefully there'll be time at the end to be able to answer all of those. So I love taking care of women. It's a pretty awesome thing. I think I fell in love with it as a medical student. And I think I probably fell in love with it a lot earlier than that. I just didn't know it. Taking care of women through the ages and everything has just been phenomenal. Taking care of pregnant women as they're going through their pregnancy, learning how to be a mom, and kind of going through the good and the bad. I think the most amazing moments and some of the most heart-wrenching moments are extraordinarily difficult for individuals, but it's such an amazing thing to take care of individuals throughout all of those processes, and I truly love it. One of the things I do want to kind of bring up is that I know we use the word women a lot. We are a women's health center, but I really want to focus on the fact that we do take care of all individuals regardless of how they identify, and whether or not it is somebody who was born with male parts and is now identifying as a woman, we still also take care of those individuals, and vice versa. If we have people who are born as female and are identifying vice versa, we also take care of that as well. It is part of our practice to really make sure that we do not genderify people in the wrong way, and that we really speak to what the individual desires and needs are. It's one of our common, if not just our practice, and I wouldn't even say common because it's what we do. We ask what people want to be known as, whether it's a he or a she or a they or a them, a z or a them, and really we want to try to embrace all individuals no matter how you identify. And I think it's important that we do that across the board as much as possible. My cousin wrote this. She's a journalist in India. I wasn't going to give her credit, but I was told I kind of had to. So this is one of the reasons why, and this just for me kind of captures the role that women play, which are women are pioneers of a nation. It is difficult to think a sustainable development in a family without a woman in the house. There are a number of roles that women's play in her life, hence it won't be wrong if we call them super women. A woman plays multiple roles in her daily life, be it a wife, a mother, an administrator, or a leader. From a mother to a wife to a businesswoman to a best friend, a woman is more than just a household queen. She always sways in different areas of her life seamlessly. One of the biggest things I always tell the medical student is, I know that all of you guys aren't going to go into OBGYN. I know that all of you guys are not going to love taking care of women's health and make this your focus. But at the end of the day, there is a woman in your life, whether it is your mother, whether it is your sister, whether it is your friend, whether it's just somebody that you randomly take care of as a provider. And it's really important that you understand issues that affect these individuals at the end of the day, because you as a medical provider are going to take care of these individuals, and you should therefore be able to speak to them no matter what they are. You can't be scared of a positive pregnancy test. You need to be able to embrace it and talk to your women and patients about it. So today's focus is specifically on taking care of women throughout the ages and understanding what the difficulties are as you start to get older. What's most interesting about all this and how we have decided how we're going to prevent some of these problems kind of goes back in history to what preventative medicine is. For those of you who don't know, preventative medicine essentially is that we take normal Nelly people, right? People who are just walking the street, have no medical problems, just living in their lives. And if they had a choice, they wouldn't have insurance, they wouldn't go see doctors, and they would just kind of live. And we are taking care of those people and trying to prevent these horrible disease processes that may actually exist. So back in the 1800s, we had the very first annual meeting of the Public Health Association. There was absolutely no distinction at that point between public health. I do not know what's happening with my screen. Public health and preventative medicine. There was a then focus later on, they were talking specifically about infection control. At that point in the late 1800s, really the focus now was on the fact that we really need to talk about and think about the fact that the majority of the disease processes are coming from water not being clean, that the refuse that we have is just sitting in areas that we do live. And then as things started to progress, we started really thinking about true prevention when it came to a medical perspective. When we get to the mid-1900s, mental health started to take a focus. And this is now probably a time that most of you are now well aware of, which is we now talk about the Preventative Task Force. And these are the individuals that decides what are the biggest issues that are affecting not only the individual, but the population at large, and how do we prevent these big issues from occurring. Then in 2010, we have the Affordable Care Act that got passed, otherwise known as Obamacare, which was actually one of the best steps in the right direction to help with preventative care measures. We started talking about not just big global issues, but individual issues that are helping individual people. In 2011, the Department of Health and Human Services now pushes forward even further and develops a women's preventative service guidelines that are specific to women, because the initial guidelines really were kind of focused on men because they were the ones who were actually getting the majority of their health care. So what are preventative measures? What are the things that we do to help prevent things? Generally, when you go to see your doctor, many people, especially when they go to see their gynecologist, they're thinking about, I'm just getting a pap smear. The only purpose that I'm here is to get a pap smear. And that's really not it. That's not the only thing that we're doing. We're doing really so much more. We are counseling you, we're doing preventative medications, we're doing screening guidelines. There's a whole grouping of things that actually occurs when we actually have you in for your visits. Some preventative measures, one of the more common things is what we call counseling, which is stopping a problematic behavior, delaying the onset of a problematic behavior, and reducing the actual impact of that problematic behavior. Now, problematic behavior, like what really is that? What do we mean by that? Well, if you think about it, problematic behavior can be something as simple as I don't wear a seatbelt, right? Well, if you don't wear a seatbelt and you get into a car accident, it's going to be horrible for you. And it's really important that we try to prevent you from having horrible things happen to you. And just by wearing that seatbelt, you have now prevented being in a trauma or something like that. And if you do end up in a trauma, what will eventually happen to you will be decreased. And that's what that part of this is. We like to try to give you the knowledge, give you the information for both not only your physical well-being, but also your emotional well-being. We want to help promote sort of community, psychosocial, and emotional well-being issues, and give you the resources that you need to be able to help with any of these problems. So I told you the one
Dr. Chawla?
Yes.
Sorry, don't mean to interrupt, but we're just seeing now the beginning slide.
Oh. Did it just go backwards in time?
Yes.
Okay, so let me try this. Let me stop sharing. I don't know what's happening with this.
There we go.
Okay. Can you still see this slide now?
Yes, we can see on slide 10. It's just
Okay,
not in
perfect.
presentation mode.
And you can still
Perfect.
see now
Great.
slide 10?
Yes, thank you.
Okay, no problem. No, thank you. I was like, sorry about that. This computer is a little glitchy. Hopefully we have no more glitches throughout the rest of this. And thank you for letting me know. And please do feel free to interrupt if it gets glitchy again. So we talked about the seatbelts, but one of the more common things that we actually bring up is counseling and prevention of, say, STIs. For those of you who don't know what an STI is, that is any sort of sexually transmitted infection, gonorrhea, chlamydia, syphilis, herpes, hepatitis, HIV. The reality is that we need to normalize these things. We need to be able to talk about these things. We need to be able to ask about who are you having sex with, what type of sex are you having, counseling about the different types of transmission, counseling about prevention, whether it's from abstinence, if you're having sex with other women, using dental tams, if you're using toys, hygiene issues. How do you keep things clean and how do you prevent yourself from getting these disease processes? Then we counsel also an immunization with respect to this. Not many people know this, but cervical cancer is actually caused by a virus. It's actually caused by human papillomavirus. And we can give you a vaccine to help prevent that, especially if you come to see us at an earlier age and in the time processes that you're supposed to be coming. So other the preventative measures that do exist are just baseline medications. This is some of the things that most of you know: taking a vitamin, taking folic acid, taking the basic things that give your body the boost that it needs in order to make it healthier. The definition of a medication is something that can be taken on a regular or semi-regular basis to prevent disease progression, prevent disease occurrence, or to reduce the severity of disease. The most common one that is written about in the literature from forever is folic acid. If you take folic acid, you can prevent what's called an open neural tube defect, which is an issue where, like, the body, as it's developing inside the woman, doesn't actually open up properly, or open up too much, and it doesn't get closed properly. And because of that, if we just give you folic acid, you can actually prevent these basic issues. So another preventative measure that we have is something called a screening test. And this is some of the things that you guys know as well. As you start to get older, getting those mammograms, right? That's another very common preventative screening test. We do the mammograms, we do breast exams, teach you about breast awareness, and all of that is combined together, a test and also a way that we see and screen for things. A test in this way is something that detects a potential health or problem or disease in someone that doesn't yet have signs or symptoms. And that's why mammogram being done in the right time at the right moment is what's important for each individual. We do this when a disease is serious. We want to do treatment and symptoms before it's actually a problem, and it is mainly specifically prevalence of diseases that are high. The thing that we have done in the past that has really hit the marker on this is actually cervical cancer prevention, and we're going to get into that. A screening test, in order for it to be a good screening test, has to have certain characteristics from a gigantic public health standpoint. And this is the part where it becomes difficult as an individual patient. You think about yourself and your individual disease, and we're thinking about the general population at large and using your individual issues to bring into that general population to decide whether or not this screening test is correct for you. From a public health standpoint, if you want it to be a good screening test, it has to be cheap, it has to be easy to be done, it can't be very uncomfortable, it has to be reliable, and it has to have these two things called high sensitivity and high specificity, and the disease has to be extraordinarily common in society. So sensitivities, it means that there's a high probability of detecting the disease from this test, or it's highly specific that the high probability that those have the disease will screen negative. So another terms for these is positive predictive value, negative predictive value, but really what it boils down to is the test is good. You don't want a test that's going to actually give you false information, because it's just going to make your anxiety level go through the roof, and that's one of the things we want to try to prevent. So as I said, the biggest one that has been extraordinarily successful has been cervical cancer. Back in the 60s, cervical cancer was the #1 cancer killer of women. And now we've been screening for over 30 years, and we have cut cervical cancer in half. And disease process, when it is diagnosed much earlier on disease. So now the question really is that, do we need to change our screening tests because we did what we were supposed to do? And the answer is, from our perspective, no, we just need to tweak it. We just need to change who's going to get screenings yearly versus every 3 years versus every 5 years, and make it so that we are actually doing this better while also decreasing the risks associated with the screening test itself. Also really thinking about whether or not there is an individual who may actually need more screening, because for that individual, they are at a higher risk, or they are a special population in which they have particular issues that make that individual problem more important to that person. So now that you kind of understand the different types of screening that we have, the real question boils down to is, when are we supposed to screen? Do we do it at every visit? Do we do it at the annual visit? Do we do it at well-woman visits? And really the answer is, it just depends on each individual, and it depends on each individual provider. Generally speaking, at an annual visit and a well-woman visit, we are responsible for doing the more gigantic screenings that are important for each individual and for the bigger issues. However, there are individual problems that happen at a, say, daily visit. If I have a patient that's coming in with vaginal discharge issues, but then I'm noticing that there's a different problem with either maybe depression or anxiety, I might now screen for that, because that's now become an issue that is more pertinent in that moment, and I need to screen and counsel and prevent a bigger problem down the line. So it really just depends. So we've talked about all the different screenings, and now what we're going to do is going to break it down into different age groups. We're obviously going to start off with the youngest, we always do, and we're going to start off with 13 to 20. One of the big things I want you to see here is in the top left corner of all of these slides, you're going to have the leading causes of death for that particular age group. These leading causes of death come from the CDC. This is data from 2017. Obviously, in 2020, the leading causes of death definitely changed, but unfortunately, we can't really use that as part of our prevention and talking about women's health. And honestly, I think a lot of us really would like COVID to be erased from society and not think about it and not even have it be a cause of death. And so really kind of taking that out of the picture, thinking about some of the other causes and preventing more of the common things for your daily life on a day-to-day basis now. And hopefully in the future, we can just have COVID kind of drop off the map a little bit and decrease its prevalence in society. So in the leading causes of deaths, when you're thinking about the 13 to 20 age group, the biggest one is what we call unintentional death. And this is sort of like the accidents. Our teenage crew of individuals, I think hopefully all of us remember these days playing volleyball, playing soccer, playing all of the fun sports. You know, some of us got a little bit injured here and there, and that's really the #1 cause of death in this age group. And because of that, the screening and the counseling are going to be focused in those areas and in those regions. And so as you can see here, you have the screening here specifically on alcohol use, blood pressures, whether or not it's something that we need to be concerned about, depression, obesity, substance abuse, and tobacco and STI screening. These are the things that are really pushing this age group, and that's the reason why we focus on those areas. Counseling on healthy activity, and then supplementation intervention. The big thing that I was telling you about was that thing called Gardasil, which is the HPV vaccine to help prevent cervical cancer. Many of my pediatric colleagues are the ones that really do the majority of this stuff, and really we lean in a lot with each other to be able to help each other out, to be able to take care of our patients as much as possible. I'm always happy to see someone in this age group if they have issues that are specifically dealing with their women's health, but generally speaking, people in this age group tend to go towards their pediatricians, which makes the most sense. This is the people that are seeing them on their yearly basis. I personally saw my pediatrician until I was 25. I did not want to give her up. And so we do have a lot of patients who are also in the same boat, because there are some pediatricians who do take care of their patients up until the age of either 21 or 25, and it really kind of depends upon insurance as well. So moving a step forward now into the older age groups, now we're moving to the age of 21 to 39. And as you can see here, things are starting to drop off and things are starting to increase as well. Unintentional death is still highly up there. It's still in now the 30% of them. And then we have cancer starts to creep in. Before it was 11%. And one of the big things that's starting to show is about heart disease. And the other big thing that's showing up here is suicide. And as you can see in the dark red, these are the things that are now added to both the screening and the counseling and the supplementation for these age groups in order to be able to decrease these issues. One of the big things of unintentional death, being pregnant, is also wrapped in here as well. At times, we do try to separate out maternal death separately as well, but occasionally it will get wrapped into the unintentional death, and something for you to be aware of. One of the big things that we do add in here is our lipid screens, which starts at 35. Those are people who have cholesterol issues. This is when we start to do our pap smears, right? Cervical cancer screening, the #1 way that we do that is our pap smears. We started at the age of 21. And then they're counseling about breast cancer risk and all of those things as well. In this age group, it's really important for us to get a really strong family history as to what has happened in your family. What is your genetic makeup? What does that genetic makeup mean for you as an individual patient? And does that change the counseling for you as an individual compared to the patient I saw previously, or the patient that I'm going to see later, or even to your neighbor, or even to your cousin who may not have the same genetic makeup as you? And it's really important to really individualize these screenings and individualize these things by this age. One of the awesome things about taking care of women through their lifetime is that over time, I'm going to know when to screen you, right? If I've been seeing you since you were 35 years old, and I know that you need to be screened at the age of 40 for colon cancer because your mother, unfortunately, was diagnosed with the colon cancer at, say, 45, we're going to know that, and we're going to make sure that you're set up for that appropriate screening at that age group in that moment. And that's why it's important to continue to get care on a more annual basis to figure out these issues for you. Moving forward to our age group, which I get to be in, this is my age group. Our leading causes of death now, as you can see, start to change. Our trauma and unintentional injury starts to drop off. Cancer really is at the forefront, and heart disease really comes in here as well. This is where we start to talk about perimenopause. Perimenopause is starting to happen. Once you go into menopause, there are so many changes that your body is going through, and really talking to you about and to actually be set up and help you through those changes is really important as well. Because cancer starts to be the leading causes of death, as you can see here, breast cancer screening and colon cancer screening really start to come to the forefront. Colon cancer screening, for those of you who are not aware, has actually changed. It used to be at the age of 50. Now we're screening people at the age of 45. So if you haven't gotten your colonoscopy and you're 45 years old, you need to start thinking about it, because this is when we're doing it. Supplementation of medicine here, we start talking about breast cancer preventative medications, especially for individuals who have family histories that are strong. And we do know that there are some ways to prevent for certain individuals, and something called statins. Statins are medications that help decrease some of our lipids and sort of decrease some of our cholesterol issues, and that really speaks to our heart disease here as well. The folic acid, what you're going to see is that's going to drop off a little bit, because once we get menopause, we no longer have to worry about getting pregnant, and so we don't really worry about that folic acid here. So now as we move into our new age group of the 52 to 64, as you can see, again, our leading causes of death kind of are up there, but one of the things that get added in here are the chronic lower respiratory diseases, and some of the other things sort of drop off here and there. Cancer is still very high, and heart disease is still very high. Because of our cancer issues, remember, we're still keeping our breast cancer screening and our colon cancer screening. We are now screening for lung cancer if it is something that you need to be screened for. Osteoporosis screening if you do need what's called a bone mineral density. One of the highest morbidity issues for older women is if they have a fall and what that means for your life. If you have a big hip fracture, that is just going to change your life enormously. Getting out of the house is going to be almost impossible. Requiring people to help you move around is going to be impossible. And then the need for your family or other individuals to be able to help you out in those moments becomes a much bigger issue. And it's important that we're really speaking to these things, and it's really important that we try to prevent these things. And you're going to see that focus as we move a little bit older into the older age groups. One of the other big things we start to add in this age group is aspirin as well. And this really speaks to the heart disease problem, and it's also one of the things that's going to help decrease our stroke issues as well. So moving on, and this is kind of where stroke just rolls in, 65 to 74, we have our cancer here again. Heart disease is now getting up higher. Our chronic lower respiratory diseases, like our pneumonias, are also getting worse. And now we have our stroke is kind of intervened here as well. And so some of those screens that are still the same, we still have the lung cancer and osteoporosis screening. In this age group, every patient should be getting what's called a DEXA, which looks at your bone density. We really need to talk to everyone about this fall prevention, making sure that your home is safe for you to ensure that you don't have any of these falls, getting rid of loose rugs, things like that. And then we still have our supplementation with aspirin here as well as there, and that's to help decrease some stroke and then the heart disease issues to help you live a healthier, longer life. Last but not least is this older group. In the top right corner are my two aunts. Unfortunately, they have both recently passed, one from a stroke and one from COVID. But I wanted to put them in here because they are my maternal heritage, and there's nothing more amazing than having a strong maternal heritage. And one of the big things about this age group and knowing that is knowing that these people are the foundations of your lives, and being able to help them live longer, to help them continue to be your foundation is so extraordinarily important. As you can see here in this age group, a lot of the little things we start to actually disappear. We get rid of lipid and cervical cancer, we get rid of colon cancer screening, and we get rid of our statins. It's an area of a little bit of controversy as well. And the reason why it is an area of controversy is because of the sheer fact that this is the moment where we start to balance whether or not we should be screening this individual and what is their true life expectancy. These days, 75 is kind of like 50 in health prevention. I would probably say in the 40s and 30s, people really were not living until 75. Well, today people are living till 100. So we as a group of providers need to change how we continue to screen individuals, because there may be a 75-year-old that actually does still need cholesterol screening. There may be a 75-year-old that does still need colon cancer screening, and individualizing that care is going to be very important. And so this kind of brings me to this point of why is it that sometimes you'll meet one provider and they think it's important to screen something, and why is it you might meet another provider and they want to screen it at a different time? Well, the reality is that the literature disagrees with each other. You could sit me and my colleagues in a room together and we will disagree just a smidge about really, really basic things. One of the really good examples of that is mammography. If you look at the major organizations that actually talk about breast cancer, whether or not you should or should not be screening anyone, how you should screen them, everybody is on a completely different page. You have ACOG, which is my society. You have ACS, which is the Cancer Society, and then you have family medicine here, AAFP, family practice here. And those are the big three that we always talk about. Well, if you look at it, we say that you should start at 40. And what we're talking about here is mammograms annually, every single year. Then you have ACS, which is the Cancer Society. They say you don't start until 45. And then you do it annually to 54, and then you do it twice a year. Then you have AAFP, who says you should start at the age of 50, and you should stop at 74, and you should be doing it twice a year all the time. So really it just depends upon what part of the literature you're specifically looking at and why you think it's important for that individual patient. For me, I kind of feel like we need to individualize care for each individual patient, and you have to think about the risks, benefits for that individual patient. If I have a patient who, say, has a couple of women in their family who've had breast cancer, then I'm going to be screening that person earlier and more regularly and talking to them about different preventative measures versus somebody who's never had any of these issues, and we're going to delay it a little bit later to that 40 or 50 mark, depending upon what their desires are. The other thing is for those of you who have not had your mammogram, it's a little uncomfortable. It's super cold. Getting your breasts smushed in the little machine, everyone always talks about it. Everyone's always scared about it. And the reality is that it can be a little anxiety provoking. But we have to get you there. We have to do the best thing for you to make sure we prevent disease. Because the last thing I want is for us to find cancer super late in stage and then we can't actually help you. So all in all, it's really important that we individualize care for our individual patients and kind of balance that with the pros and cons for that individual patient's history and issues. And that's truly preventative care for what we like to call the N of one, the one person that's sitting in the room across from you that you're sort of trying to take care of in that moment. Okay, well, that brings everything. If you guys have any questions, I'm happy to answer them. Otherwise, I'm also happy to see you as a patient. We are definitely accepting new patients. For those of you who don't know where I am, I'm actually in the clinical office that I actually see patients in. This is the surgical subspecialty suite. It's right above the emergency room here at the University of Maryland Midtown Campus. That's the phone number that you can call, the 410-706-2500. And please ask for the Midtown Campus location. And also, if you have any further information, you can go to our website. Things that we're offering to almost all of our patients that are here, any OBGYN services, annual exams. We do have a full midwifery practice, and we are providing pregnancy and prenatal care and also menopausal care. And if you are a patient who has like total normal, we're happy to sort of help you with your annual preventative screens as well. And I hope that that's helpful.
Great. We do have a few questions in the chat.
Okay.
The first question is, what's the difference between an annual visit and a well woman visit?
That is actually an awesome question. Stop. No, I want to keep sharing my. Is the screen still being shared, Kate? I'm just trying to figure this out as well. Okay. I'm trying to stop that, but I don't think it's going to let me. Stop.
There you go.
Okay, perfect. Thank you. I was like, I'm not really used to this webcam scenario, so I apologize for the glitches. You know, that's a really excellent question. An annual exam versus a well woman exam. They actually can be the same thing depending upon what specifically is happening on that visit. Many women will get what's called an annual exam with their primary care provider, but they won't do some of the specific issues that are dealing with both women's health issues like cervical cancer screening and breast cancer screening. Many primary care physicians, internal medicine docs, family medicine docs won't do pelvic exams and don't do breast exams. And so they have their gynecologists do that well woman component and do that well woman visit. And we will kind of take those aspects and really focus in those areas and kind of focus in on the other aspects of true women's care, which is like menopausal screening, talking about contraception, and those types of things as well. There are many family care providers and internal medicine providers that do both and will actually be able to do all the things in one single visit for you, but there are some that do not. For myself and many of the colleagues in my practice, we will do both for you if you are not medically having any issues that requires further treatment. Like if you're having high blood pressure issues or if you're a diabetic, we really want you to have good care with your primary care physician so they can control that and then deal with the aspects of care that would put you at a higher risk in that annual visit. And then they, if they're not comfortable with doing your breast exam and pelvic exam, will have you come to us to do those aspects of care. And so when you come to see me, that will be your well woman visit. I hope that answers your question.
Yes, thank you. Next question. Can you clarify the frequency in getting a pap smear yearly versus 2 to 3 years? And why
that is a really awesome question. It keeps changing, unfortunately. My residents are always like, what are the new guidelines? And it can be very confusing. One of the things that you should be aware of is that we actually do something a little bit different now than we used to do in even the 2000s. We do what's called co-testing. Well, so when we put the speculum in and we look at your cervix, we're actually testing for cells and we're actually testing for HPV, specifically the high risk strain, which is what causes cervical cancer. So we're looking specifically at high risk HPV. If you get co-testing, so if the provider, when they did your test and you're doing both tests at the same time, the recommendation, if both tests are negative, that you do not need to come back for a cervical cancer swabbing for 5 years. And so for those of you who are asking is how frequently I get my 5 years, starting at the age of 30, if you're doing co-testing, you don't need to do it except for every 5 years. Now between the ages of 21 and 30, it's a little different. We only do the cells and we don't test for high risk HPV. And it's a really long answer for why we don't do that, but we just don't do it right now. And so what we're specifically looking to see if there's any abnormalities, and in that age group, we're doing it every 3 years. Now, if either one of those tests come back as positive, or there's something a little bit different on your results, that screening interval will change. There are many patients that I have that I will be seeing them every year due to the fact that they're immunocompromised, they've either had an organ transplant, or they're on medications that makes their body not have as strong an immune system as another, what we call immunocompetent or fully like immune patient who has all of their stuff and is working really well. If their immune system is a little bit suppressed, that person might be coming back more frequently because they have a higher risk for having changes. So the answer is, if you have no problems, it's every 5 years, between 30 and up to 70, and between 21 to 30 every 3 years. And then there's some nuanced differences within that.
Great. And then there was a second part to that question. Will insurance pay for yearly pap smears if I request and a doctor co-signs?
So it depends upon your insurance is the real answer. Most insurances these days are catching up to the guidelines, and so therefore will not pay for annual screens if there's no medical indication for you to get an annual screen. So it really depends upon A, your insurance, and B, what your specific history is and whether or not it is indicated for you to get a pap smear in that given year. So it's a little bit variable. If you do a pap with HPV testing, if I remember correctly, it will cost you probably about $50 out of pocket to do it if the insurance does not cover it. So that's just something to be aware of, but don't quote me on that because it might be different depending upon where your pap and HPV test goes.
Great. Another question, is menopause due to endometrial ablation any different from menopause that occurred naturally? I had an ablation in 2016 at 51 due to a heavy period that wouldn't stop.
Yeah, so that's actually a really interesting question because it kind of goes to what the definition of menopause is. So for those of you who don't know, menopause by definition means I haven't had a menstrual cycle for a year. Well, what's kind of interesting is this particular patient that just said that she had hers in 2016. Well, because of the ablation, she's not having menses anymore. But in actuality, menopause is when your hormones really aren't doing what they're supposed to have been doing, or they're just not doing what they were doing before for a year now. The external expression of menopause is your menstrual cycle, but what your body does during menopause is really the signs and symptoms of it. And so the signs and symptoms of menopause are going to be your hot flashes, are going to be the mood changes, it might be the night sweats, it might be inability sleeping. And that's something that, especially for you who no longer has that external ability to see whether or not you're actively menstruating, would be something that you might want to talk to your physician about to see whether or not you are or you're not in menopause from a hormonal perspective. There is a blood test that we can do that can give us that information. And for my patients that are no longer having menstrual cycles, either due to a surgical procedure, due to something that happened to them medically, or due to even a hysterectomy, we will talk about what it means for you and when your body and your ovaries physically go into menopause, and when we start doing all of those screenings that are different for you compared to when you're not actually in menopause. So it's a little bit of a moving target to know whether or not somebody's gone into menopause if they no longer have menstrual cycles because of something like that, like an ablation.
Okay, and then I think this is our last question. Is folic acid something that you can get over the counter, or do I have to ask my provider for that?
Both. You can get it over the counter and you can ask your provider. If you go into the vitamin aisle, there's like 9,000 different types of vitamins. And for those of you who are trying to get pregnant, there's going to be prenatal vitamins that are there as well. And there's all the different variations and all the different things. Most prenatal vitamins will have baseline folic acid for women who are just baseline trying to get pregnant. If you've had issues in the past, you need to take more folic acid. So from a perspective of if you're trying to take folic acid for prevention for that pregnancy thing that we talked about, just taking a basic prenatal vitamin rather than a multivitamin is your best bet. and it'll cover all of the things. In order to be labeled as a prenatal vitamin, you have to have a baseline amount of folic acid, and there's a couple of other things that are important for your bones and health in general as well. And so it's not a bad thing. I have a lot of patients who are not trying to get pregnant and take prenatal vitamins because they think it tastes better and they like them. And I think that's okay as well. You just don't want to take too many of certain vitamins, and that's something that we can discuss individually depending upon what your medical issues are.
Great. I think those are all the questions that we had come through the chat.
Okay.
Thank you so much for joining.
Yeah,
and those who registered, and also for those who joined today, there'll be a copy emailed to you tomorrow of the recording of the webinar. So please feel free to share it with all the women in your life as well.
Okay, thank you, everybody. It was very nice meeting you in this virtual world. I hope to see you around campus soon.
Thank you very much for your time.
Absolutely.